Lindsay is a CESP alum, undergraduate. I just learned today, which I didn't know. So she's back on campus, and she is in Feinberg in preventive medicine, social epidemiologist. So we'll hear about her work in a moment. She has an MPH from Emory University and then got her PhD at the University of Michigan. And then she came to Feinberg as a postdoc and now has transitioned into a faculty position. So we're excited to hear about her work and have her here. We had scheduled her for a talk in, I think, April or May of 2020. So we're, finally getting around to that. What's that? Yeah, what happened? I don't know. Yeah. Anyway, Patricia has asked me to remind you to turn off your cell phones or to mute them. And I'm going to turn it over to Lindsay and let her moderate questions. I'll interject with questions from the remote audience. And if you ask a question, if you could identify yourself with a microphone so everyone can hear, that would be great. All right, Lindsay.
Thanks so much for having me. I'm going to go ahead and take off the mask and I will put it on before anyone approaches me. That way everyone can hear me. I heard that there is a substantial number of people on Zoom as well. So hi out there to the Zoom. And thank you everyone in the room and on Zoom for having me. I'm really excited to be here and talk to you today about a little bit of my research that I've been doing on the Affordable Care Act along with my colleagues related to cardiovascular health intervention. For those of you who haven't had the opportunity to come down to our Chicago campus, this is a nice picture of what you will see if you are getting an aerial view of it. Okay. Where is, there, okay. Figured it out. Dr. McDade already gave a great introduction, but I just wanted to say a couple things about myself and preventive medicine for those of you who are a little less familiar with preventive medicine as well. So I'm back today in Evanston after a extended time away. I did my undergrad here in social policy, which explains partially why I am interested now in evaluating policy in my role as an epidemiologist, but my career has been focused in epidemiology, particularly social epidemiology. I'm interested in the social determinants of health and how they impact life course development of cardiovascular risk, which I will be talking about today, and evaluating macro level interventions for that risk. And for those of you who haven't had the opportunity to interact too much with the Department of Preventive Medicine down at Feinberg, we are a mix of epidemiologists, biostatisticians, and health behavior scientists. And some of us are clinicians and some of us are of other PhD backgrounds. And a lot of what we do is large population cohort studies. We do a lot now with electronic health records. And we've got a big group that particularly is focused on cardiovascular disease prevention. That's a big focus in our department, not the only focus, but indeed our chair is actually the current president of the American Heart Association. We have a lot of people who are really focused on that. And I am always looking for new people and new ways to collaborate. So as many of us are, and so just wanted to put that out there. So today I have a couple objectives. One is to review some recent trends in cardiovascular disease risk factors and outcomes, and then talk briefly about the life course process of the development of cardiovascular risk, and then fold that into the impact of the Affordable Care Act on both access to care and in particular cardiovascular outcomes, and then talk about some of the limitations of policy targeting access to care in terms of how we can mitigate cardiovascular risk. So there was big news in 2015. So much has happened in the world. It's like hard to remember pre-pandemic life. But this was big news in 2015 that there was a decline in US life expectancy. So this graph shows an uptick in life expectancy that occurred over the past half century. But then we do see that in the teens, that life expectancy started to plateau, and then in 2015 declined, and then continued to decline over the next few years, and now with COVID has declined even further. So this was sort of a trend that came to stay, and there was lots of hand-wringing about why that might be the case. And so some of the initial hypotheses were related to the stark increases in drug-related mortality that went along with that same observed decline in life expectancy. And so we can see here on these graphs, and these are different, broken out by different age ranges, and these are different causes of death, these different colored lines, and these are years along the x-axis. We see these black lines going up and up in each of these graphs pretty starkly, and those are drug poisoning deaths. And then also was talked about deaths of despair, which include drug poisoning, but also suicide, with these purple lines going up, particularly in younger adults that we saw these increases. And so was it drug-related deaths? Was it deaths of despair? What was really causing this life expectancy decline? Some researchers went along further and looked at the contributions of cardiovascular disease. And so it's partially a numbers game, right? So the cardiovascular disease is the leading cause of death in the US. So if there's fluctuations in CVD mortality as a result, necessarily, we're going to see those reflections in all-cause mortality, but also in life expectancy. And so life expectancy is sort of more dependent on younger people than older people, but CVD has a range in which it impacts, and certainly because of the sheer volume of CVD deaths, it impacts life expectancy as well. And so in this particular study, some colleagues, what they did was look at what did happen in terms of life expectancy. And this is broken out for women and men, and looked at what happened in terms of actual life expectancy change, which is in the black line, and then a counterfactual, which is if things had gone the same way they did in terms of CVD mortality trends and drug-related mortality trends that they had seen prior to 2010, what would life expectancy have been? And really, it was true that drug-related deaths did impact that life expectancy, that we would have seen a slightly higher life expectancy in women and particularly men had we not seen the great increase in drug-related deaths. But really, CVD deaths did seem to be having an impact on that differential in the life expectancy that was observed versus what would have been expected. And so all of this comes together, and then we say, why? Why did CVD have this impact? What happened with CVD mortality? So the thing about CVD mortality is that the long-term CVD trends were actually a success story. So these are, again, broken out between men and women. And what we saw was that in the past half century, that the deaths from heart disease were declining in men and women, both very strongly, very strong decline, stronger than cancer, stronger than stroke, very strong heart disease deaths. But what happened, and you can kind of see it on this graph right here, is that around 2010, that strong decline began to plateau. And we see it here, the dots are starting to plateau, both in men and women. And if we unpack that a little bit more, and look actually at in this paper where some colleagues pulled it out until 2018, what we see is that this inflection point, which is right around 2010, 2011, is that the declines in heart disease, this is total heart disease right now, declining, 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 and then plateau, plateau, plateau. And this is broken out by race and by gender, but we saw the trend the same in each of those race and gender groups, black and white, men and women, this decline, 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 and then a plateau. But when we further break it out by CVD subtypes, so we have different types of cardiovascular disease that one can die from, and ischemic heart disease, which is what we think of like heart attacks and coronary artery disease, that is the biggest contributor to overall heart disease death. And we see it here that is having that same pattern of decline, 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 and then plateauing. But when we look at other types of heart failure, we actually saw an even more disturbing picture, which is heart failure and hypertensive heart disease were pretty much a steady state in the 2000s, and then have actually begun to pick up in the past decade, and those trends are now increasing. And so what we see is that it wasn't actually that heart disease deaths just plateaued. Some heart disease deaths are actually increasing over time, which is an even worse picture, and certainly for life expectancy, why we might be seeing some of those trends emerge overall in our larger picture of health. So let's talk about CVD mortality. CVD mortality is a late stage outcome. It is the culmination of a decades-long process of disease development where there are a lot of opportunities for prevention along the way. And so this is something, this colored graph here is something that we talk about in public health a lot. And this is the stages of prevention. So where can we intervene to prevent disease from developing? And you'll see one of these created for nearly every disease, nearly every health outcome. And here it is for cardiovascular disease. So this is sort of the overall what we see in terms of prevention and how we talk about it. And then specifically, what does it mean for CVD? So when we talk about primordial prevention, we're talking about the preventing the development of risk factors. And this is really where we see our public health prevention, where we're targeting the general population to promote maintenance of cardiovascular health. This a lot of times is policy or global prevention programs. We get then to primary prevention, where we're preventing the onset of disease. And this is where we're targeting high-risk individuals, those who have CBD risk factors like high blood pressure, high cholesterol, or diabetes, and getting individuals to manage those conditions in the hopes that they will not develop clinical cardiovascular disease. Secondary prevention is when we get early diagnosis and prompt treatment. So looking at preclinical CVD, hardening of the arteries, but we want to prevent that eventual major cardiovascular disease. So that hardening of the arteries, but we want to prevent the heart attack or the CVD death. And tertiary prevention is really individuals who already have CVD developed, but we want to prevent a serious event. We want to prevent disability. We want to prevent mortality from occurring. So when we're talking about CVD mortality, we are preventing here in the tertiary prevention, but we've got a whole life course in which to be preventing as well. And so part of why we saw those really strong declines in cardiovascular disease death over that half century was because we had great interventions in nearly every stage of prevention. So we had really good new cardiovascular interventions, things that we could do when people came and presented with a clinical CVD event to keep them alive. We had new imaging techniques so that we could diagnose cardiovascular disease and be able to spot it before somebody had a heart attack or a major event. And we had great new interventions for those at high CVD risk. Statins, which you take if you have high cholesterol, were a particular success story in which people taking statins had much reduced risk of cardiovascular disease development. And finally, primordial prevention, tobacco cessation was a particular success in primordial prevention as well. But with all the successes, we had some issues come up as well. And one of those big issues, which was the obesity epidemic. And so everyone's pretty familiar with the fact that obesity has risen dramatically in the past 40 years. And so the prevalence of not just obesity, but extreme obesity has gone up. It's gone up in men, it's gone up in women, and pretty steadily gone up over time. And so what we see is that, you know, with all of this increased obesity, we've been sort of waiting for when that was we were going to see the larger health impact of that. We knew that this is something that is an extreme risk factor for cardiovascular disease, as well as many other causes of death and disease as well. And we're beginning to sort of see that manifest in the actual cardiovascular mortality in the late stage cardiovascular disease manifestations. And so now that 40 years have passed, and when younger individuals, children, were starting to become heavier and the average BMI is going up and the prevalence of obesity is coming up, now you have those individuals in middle age and they're starting to present with cardiovascular disease. And so the obesity epidemic is now sort of rearing its head with cardiovascular disease mortality and as a result, life expectancy changes. We see that as well with diabetes, that the prevalence of diabetes has risen, and obesity is a big risk factor for diabetes. So here, actually, this line is the prevalence of obesity and how that's gone up over time. And here is the prevalence of diabetes, which has also gone up over time. This is the late 80s, early 90s, 5% prevalence of diabetes in the US. This is nationally representative data. And here is 2005 to 2010, we have 9%. And so that's a big change, right? So now we've changed where there's a primordial prevention issue, and now we have high-risk people where we're trying to prevent them from getting, they're at a further stage down the road in terms of the prevention that we can do for them. And we want to keep them in a state of cardiovascular disease-free health, but they are certainly now at a higher risk. And finally, when we think about hypertension, so hypertension is incredibly prevalent in the US. 30% of adults have hypertension, but that prevalence goes steadily up as age increases, and nearly all older Americans have hypertension. And here's the thing is it's not just the prevalence, but it's also the control. And so when we say control, we say, can we use effective interventions like medication to bring people into a blood pressure state that is not reactive for the development of cardiovascular disease? And so this graph here, again, is nationally representative data for the US and is looking from 1999, 2000 up until the late teens about blood pressure control among those who have hypertension. So we see that we were increasingly able to control blood pressure for those who had hypertension. We continually have new classes of medication being developed, better interventions, but around about 10 years ago, that started to decline and blood pressure control was declining. And here's the thing, it's not just an access to care issue where you have more people who have hypertension who aren't getting the medications, because when we drill down and look at those who are specifically taking hypertensive medications, we saw that same dip that hypertension control was going down. And so it turns out that when we have this hypertension that's responding less well to medications, it's what we call resistant hypertension. It's resisting the medications. And a big risk factor for resistant hypertension is actually obesity. So we have the obesity epidemic is now coming full circle, and here it is impacting cardiovascular health. And so this is just a big backstory of what's been going on in cardiovascular health. And now let's talk about something else that happened in that same time period, which is the Affordable Care Act. And so now I know that I'm speaking to a policy keen audience, and that some people are even more knowledgeable about the Affordable Care Act than I am. And so coming to you a place where I know that many of you are very knowledgeable, but just as a bit of background about the Affordable Care Act. So it was a comprehensive health reform aimed at expanding healthcare coverage, controlling healthcare costs, improving the healthcare delivery system. And it had this series of provisions. So even though it was signed into law in 2010, it was sort of implemented over time over the past decade with different provisions aimed at individuals versus employers, insurance companies, and state-run public health entities. And as we all are familiar with, because it's certainly gotten a lot of press, there were a lot of legal challenges and on some provisions in particular, including the state level requirement to expand Medicaid to all low-income individuals under the age of 65. So this was supposed to be an expansion that happened across the US. And as a result, because of the Supreme Court ruling, some states chose not to expand Medicaid, which was unfortunate for the people living in those states who wanted that insurance expansion. But as for us as researchers, became a great natural experiment to compare outcomes in states that did and did not extend Medicaid. And so I'm about to show you a lot of research that I've done and that others have done, and nearly everyone has been exploiting the difference in distance estimation method to compare trends before and after the Medicaid expansion in states that did and did not expand Medicaid. So being able to compare in that way and use that natural experiment to understand the trends and outcomes. And so just a couple of key dates when we think particularly about cardiovascular disease for insurance and preventive care coverage. So the ACA was signed into law in March 2010. And before Medicaid expansion even occurred, something that was important for cardiovascular disease prevention was that health plans that were existing were required to cover preventive healthcare services. And so this this preventive care benefit was to have first dollar coverage for all services that were rated A or B by the U.S. Preventive Service Task Force. And so that task force reviews all the evidence on different prevention methods in medicine and gives them a rating. And anything that had a high rating, the law required that there be first dollar coverage, meaning someone didn't have to pay a copay or have it applied to their deductible. And this is important for cardiovascular disease because when we think about our primordial and even more than that, our primary prevention, many of those prevention methods that we use are actually rated A or B by the U.S. Preventive Services Task Force. Which as a result, this coverage we hypothesized could actually have a change for cardiovascular care coverage, particularly amongst those who are high risk. So something like having a blood cholesterol check could be covered now, first dollar coverage, and might encourage more individuals to be using that. So that's why I am particularly focused on the preventive care coverage here in this timeline. But certainly the overall coverage mattered as well. And so things like the dependent care coverage expansion, where individuals were covered up to age 26. And then in January 2014, where we have the individual health insurance mandate with the Medicaid expansion, but then also insurance regulation changes too, things like guaranteed issue, where people with pre-existing conditions couldn't be denied coverage or kicked off their insurance, also has an impact on cardiovascular disease prevention too, for those people who have cardiovascular disease, have previously had a heart attack, now have to be included as well. And so all of this seemed very important for the Affordable Care Act. We're excited, but you know, it didn't take long for people to notice that these trends were happening at the same time. So this is just something from the Wall Street Journal published in 2017. Why didn't Obamacare work? This week brought more evidence. The Obamacare experiment has not made Americans healthier. Life expectancy in the US fell for the second year in a row in 2016. It's striking that the implementation of a massive expansion in federal health benefits has coincided with the reversal of a long-term trend in increasing US life expectancy. At minimum, it should inspire politicians to stop equating rising health appropriations with better health. So this is certainly one individual's opinion, but you know, I think that people started to say, well, okay, if we just implemented this thing that's supposed to make people healthier, why does it seem that people are getting less healthy? And of course, if we're sort of drawing the line that we have already been drawing, if life expectancy declines were driven by changes in CVD mortality, then isn't the question, why didn't Obamacare work for CVD mortality? Well, let's talk about that a little. Did it work? So a couple things. Did Obamacare work in terms of health insurance coverage? And this is from a paper written by Ben Summers and colleagues, and he has now made his whole career out of Affordable Care Act evaluation. But in this article, we saw that almost immediately the proportion of uninsured individuals dropped, that once the health insurance exchanges opened and once Medicaid expansion started occurring, that fewer and fewer people were uninsured in the US. And that happened very quickly. And this is a graph from the Kaiser Family Foundation, which also shows sort of the prevalence of uninsured in the US over time. And we do see that big decline from 2013 to 2015, but then it sort of plateaus around that point in time. So did Obamacare work? Well, it certainly reduced the number of insured people in the US, although we still certainly have about 10% of Americans who are uninsured. And so it hasn't completely reduced health uninsured population to zero, but we have seen some declines. So did Obamacare work in terms of care affordability? So this was another big piece, literally in the title, the Affordable Care Act. Did it actually make care more affordable? And this is another piece from Ben Summers' group, and it looks at changes in coverage and access to care. And this is particular in access to care and affordability. And so this is looking at a Medicaid expansion versus non-expansion states, and the change in different pieces of medical cost hardship hardship. And what they saw was that in states that did expand Medicaid, there was an increased percentage in people who said they had a usual source of care, which is a big access to care marker, and 18% decrease in cost-related delays in care, 11% decline in cost-related medication non-adherence or skipping due to cost, 14% decline in trouble paying medical bills, and a 30% overall decline in annual out-of-pocket medical expending. So certainly there were significant declines in medical cost hardship in Medicaid expansion states. So that looks like a success story. We can also look, so that was particularly among people who are, so that because this is looking at Medicaid expansion, it's then necessarily going to be evaluating people who are going to be covered by Medicaid. When we look at sort of a nationally representative group, this is an analysis that we did looking at all US adults and then particularly high CBD risk, which is people who said they have hypertension or diabetes, and their prevalence of different pieces of medical cost hardship in 2011 versus 2015. We do see that among all US adults, regardless of their coverage, problems paying medical bills declined, both in all US adults in high CBD risk, foregone care due to medical cost, and medication non-adherence due to cost. All of that goes down, but we certainly see at the end of this analysis in 2015, once we have applied that additional health insurance coverage, we've given more coverage for preventive services and gotten rid of some of those insurance barriers, we still have about 20% of high CBD risk individuals who have trouble paying their medical bills, and about 10% are foregoing care or medication. And so if we're trying to eliminate all of those barriers to CVD prevention, we're not quite there yet. So yes, it did work that it went down, but it's not at zero yet. And so did Obamacare work in terms of preventive service usage? And so this is another analysis we did in the same vein, looking at 2011 and 2015. And this is simply a nationally representative proportion of individuals reporting these different preventive service usages that are specific to CBD risk. So how many people were, what percentage of people were getting a blood pressure screening? It went up very slightly. Cholesterol screening goes up by 5%. Diabetes screening goes up by a couple percent. Diet counseling and smoking cessation counseling. And so these do go up a little bit, and this is statistically significant, these differences, and you think this is nationally representative data. We've now got millions of more people who are being screened for these CVD risk factors and hopefully getting treated. And so, but does this really matter in terms of actual statistical significance? And we can look at excuse me, sorry. This is from the Ben Summers paper before, where they looked at the changes in coverage and access to care and utilization, particularly related to the Medicaid expansion. And they saw after Medicaid expansion, they didn't really see that much difference in preventive service usage, that there was not a significant change in cholesterol checks in the past year, even among high-risk patients, or glucose checks was sort of on the borderline in terms of percentage increase, although they did see, particularly amongst those with diabetes, more glucose checks. So we're sort of wondering if preventive service usage really went up, how much did it go up, and did it go up amongst low-income individuals who maybe were disconnected from care before? Not quite sure. There is a signal here that there wasn't much difference overall. So when we think about did Obamacare work, what are our hypotheses related to CVD, and could Medicaid expansion be associated with a change in CBD mortality? So we can hypothesize that if there's greater health insurance coverage, we can manage CVD risk factors better. People will go to the doctor, get early stage disease detected, and we can prevent that morbidity and mortality. We can hypothesize that if there's limits on cost sharing to patients and we encourage care seeking, then we can prevent CVD morbidity and mortality by increasing care seeking and medication adherence, which is a big piece of CVD prevention. And then we can hypothesize that first dollar coverage of recommended preventive services can then lead to additional screening and treatment of CVD risk and prevent with our primary prevention. So we can have all these hypotheses and do some work to evaluate to see whether or not we did move the needle on CVD mortality. And so this is a piece that we are about to get published in the Journal of General Internal Medicine by myself and colleagues looking at cause-specific mortality. So this is all the causes, the major leading causes of death in the US, and then specifically natural causes, so not related to injuries or suicide or homicide. But when we look at the different causes of death, and this is looking at expansion states and their mortality rates before and after the expansion and non-expansion states, what we saw was that we didn't actually see a difference in the change before and after expansion in terms of all causes of death. So death rates did increase in both groups, which is kind of what we saw before, that life expectancy is going down, that mortality is going up, but we didn't see a difference. And we actually didn't see a difference with cancer deaths either. Cancer is still having a success story where their mortality rates went down in both groups of states, but there wasn't a difference there. But what we did see is the diseases of heart, which is cardiovascular disease, but then a pretty broad definition of that. And we did see that there was a significant difference between expansion states and non-expansion states. But when we actually look at these trends, we saw that there wasn't too much of a dip, a non-significant dip in those expansion states. So it wasn't that we really were improving CBD mortality in expansion states, but we were sort of stemming what was an increase in the non-expansion states. And so what could we conclude from here was that maybe that Medicaid expansion was sort of stopping some of that increase rather than really reducing CVD mortality overall. And there was another paper that was published right around the same time, that was published a year or two ago by some colleagues who actually did an analysis where they looked specifically at CVD mortality and found that there was a significant difference between Medicaid and non-Medicaid expansion states. And so why do these numbers look different? This is 146, and we saw in the previous slide that this is like 55 and 54, and that's just where we're doing sort of different coding of CVD mortality versus all diseases of the heart. But when we drilled down specifically on CVD, we still saw this difference. And then we published a paper recently too, myself and colleagues, where we further drilled down on CBD subtype. Okay, so remember we were seeing differences in the trends of CVD mortality over time in the past decade. And so we looked to see, okay, well, from those different causes of death, particularly related to CVD, how did those differences align? And so we did see, this is still like the same pattern we saw before, where that overall CVD, we do have a significant difference between Medicaid and non-Medicaid expansion states, but we don't see it for ischemic heart disease, and we really see it in hypertensive heart disease and heart failure. And again, okay, so we see a little dip in hypertensive heart disease where it's going down, the rate's going down in expansion states, but it's going up in non-expansion states. And in heart failure, it's pretty much staying the same in expansion states, but increasing in non-expansion states. So we're wondering too, if we're actually nudging CVD mortality down, or is it really that in non-expansion states, that's where we're seeing the increase? And if the ACA did anything to CVD mortality, did it really just stop that increase rather than lead to true declines? And then this last piece that we have worked on is looking specifically at in-hospital mortality. So we looked at hospital-related discharges, and what we saw in this graph is looking from 2009 to 2014, and looking at, these are non-Medicaid CVD hospitalizations. And the trend over time was pretty flat in terms of what type of insurance people present to the hospital with. And so up here is private insurance, both in expansion and non-expansion states. And then down here is Medicaid and uninsurance in expansion and non-expansion states. So here, this blue line is Medicaid in expansion states, which we see had a big jump for 2013 to 2014, in which people are increasing in Medicaid coverage. And then down here, this dashed line is uninsurance in expansion states, and we see concurrently a big dip in uninsurance. So what we're seeing is uninsured individuals really, in terms of CVD hospitalizations, were really now being covered by Medicaid more than uninsurance. That's where that change occurred, rather than into private insurance. And what we didn't see was really any difference in the non-expansion states for uninsurance and Medicaid insurance, that those stayed pretty flat over time, didn't have those big changes. And so this is just more talking about insurance coverage, but what does this mean actually for in-hospital mortality? So if more people in the expansion states are now being insured through Medicaid and fewer are uninsured, is that going to affect overall in-hospital mortality? And the answer was no, that we did not see any significant difference in in-hospital mortality. So this is basically somebody comes to the hospital, I had a heart attack. Okay, well, do you die in the hospital or do you live in the hospital? So that's what we're talking about with in-hospital mortality. So it's a very late stage indicator again, because this is somebody who is already at the point where they're now having that CVD event. But does it matter in terms of quality of care? Does it matter in terms of severity of disease? And we didn't see any difference from that coverage. And then two other papers also looked at specifically acute myocardial infarction, that's a heart attack, or heart failure, and didn't see any significant difference there. So we don't see the needle moving there in terms of in-hospital mortality. So we do see some changes sort of globally with CVD mortality, but we didn't see in-hospital mortality specifically changing. Yeah.
I have a clarifying question that came in from Joe Feinglass. Was the expansion state mortality analysis restricted to age 18 to 64, the population most affected by the ACA?
Yes, it was. So these are non-Medicare hospitalizations. So as a result, you're going to have, I think we age restricted it too, but this sort of as a result gets age restricted by excluding Medicaid and Medicare hospitalizations. Good question. And then the last piece of this that I wanted to cover was thinking about CVD risk factor conditions. And this has been a little trickier because we wonder what constitutes a policy success. So we don't want the underlying population prevalence of these conditions to increase. We don't want more people to be getting hypertension or more people to be getting diabetes, but we do want the awareness and treatment to increase of these conditions. So I might have hypertension and be walking around and not know it. So we want me to know it, and we want me to be going to my doctor to get treated for it, but we don't want more of me's who have the hypertension to be walking around. It's really tricky in terms of the data that we often collect to be able to analyze this effectively, because most of our big data sources that are nationally representative or have a large sample size rely on either self-report or physician diagnosis of risk factor conditions. So in order for me to tell you that I have hypertension, I have to know I have hypertension. In order to look at my electronic medical record and see a diagnosis of hypertension, my doctor has to know I have to have gone and gotten that. So what we are actually then expecting was wondering if higher prevalence of some of our CVD risk factor conditions after the ACA was enacted and some of these provisions come into effect, would that actually change our prevalence of would that actually change our prevalence of the disease, or would it just mean that we have more awareness of the underlying disease? And this is a paper that we have in press. It's about to be published, where we looked specifically at hypertensive disorders of pregnancy. So that's looking at both hypertension in pregnancy and people who come into pregnancy already having hypertension. And what we saw was there was larger increases in Medicaid expansion states. And so in these graphs, the expansion states are in blue and the non-expansion states are in red. So we certainly saw that there was more hypertensive disorders of pregnancy in non-expansion states, but that gap is actually closing. We see more people in expansion states being diagnosed with hypertension, and it's even stronger in this hypertension and pregnancy. And so part of this is us saying, okay, well, now that we're covering people and we're covering them more effectively, are we simply diagnosing more of these conditions rather than having an impact in that way, which makes this a little tricky to evaluate and understand, particularly in the short term. So let's talk briefly about the limitations of the Affordable Care Act. This is a schematic where we're looking at the different social determinants of health and CVD prevention, and there is a lot that's going on. And here is access to medical care, and affordability is right here in this piece. So when we are intervening on healthcare affordability, we aren't getting at the global picture of everything that's a determinant of health for CVD prevention. These are all, first of all, just social determinants, and this is one little piece of that. And then we have also non-social determinants of health, things like genetics and epigenetics and different behavioral risk factors. There's a lot that goes on there. So if we want to intervene just on affordability, we can't simply get rid of all of our disparities in CVD and change all of our CVD trends. And so this is just another piece of work that I do, and I just wanted to highlight it for all of you to understand the importance of primordial prevention for CVD mortality. So we have been backing up earlier and earlier and looking at CVD risk across the life course. And so the stratification of CVD risk is already present by early childhood. And so in this particular paper, we saw that by age 8, we had 3 different groups of CVD risk, and this is looking at different trajectories, so group-based population trajectories, and how people sort of change with their CVD risk across the life course. And all of this is related and associated in research with subclinical CVD in middle age. So what happens at age 8 matters in terms of decades later, if the likelihood that somebody's going to have CVD. And actually recently, we just have a paper we're about to submit where we further backed it up looking at electronic health record data, and see by age 2, we actually have that stratification of CVD risk. And so all the access and affordability to care in the world is not going to get at this primordial prevention piece, where we really have to be thinking critically about what is going on in terms of the stratification of risk and what matters. So these aren't people who need to go to the doctor and be intervened on. These are people who need to be intervened in terms of diet and physical activity and obesity and those things that are sort of extra to the healthcare system. And so in summary, I want to say, despite the changes in life expectancy and CVD mortality, it appears that the ACA did have some success with improving healthcare access, certainly, and some prevention of CVD mortality, whether or not that was just sort of reversing worsening trends that could have occurred, particularly with hypertensive heart disease and heart failure. But there's still work to be done in terms of healthcare access. We need even more improvements to affordability and other access components that don't have anything to do with affordability, like transportation and quality of care and all the things that make up healthcare access beyond affordability. And finally, primordial prevention is very much needed to improve the CVD health outcomes. If we want to think about downstream things like expectancy and CVD mortality, we need to be thinking upstream and very early in the life course with policies that target that particular primordial prevention. And I'd like to thank a lot of my collaborators on the different pieces of work that I presented today, and the National Institute for Heart, Lung, and Blood, the National Heart, Lung, and Blood Institute, and the American Heart Association, which have funded most of this work. And I'm excited to answer your questions. Thank you.